Welcome, and thank you for joining us this afternoon. I'm Andrea Whitsett, Director of Morrison Institute for Public Policy at Arizona State University, and I'm so pleased to present Housing is Healthcare, and especially to be presenting this during May, which is Mental Health Awareness Month. So just a few quick housekeeping items before we begin. First, I invite you to use the Q&A function at any time during the webinar to communicate with us. We'll try to respond promptly to any tech issues, and then for your substantive questions, we'll be holding those for the panel discussion at the end. In terms of the agenda for today, we're going to start by framing the problem: people experiencing chronic, serious mental illness whose needs are not well met. And then we'll be hearing from researchers who took an in-depth look at the costs by housing setting for these individuals in Maricopa County in what is truly a first of its kind study. Then we'll be hearing recommendations to improve the system that were gleaned from numerous interviews. And lastly, we'll wrap up with a panel portion. And in the interest of time, we'll be using the chat to share information throughout, such as the presenter bios, links to the report and the explainer videos, links to resources. So keep an eye on the chat to follow along. And now it is my pleasure to introduce our opening speaker, Watts College Dean Jonathan Capel, who will be framing the issue and providing context on why we engaged in this important and actionable study. Dean Capel.
Thank you, Andrea. I'm absolutely delighted to be part of this webinar today, and particularly pleased to see the participant number continue to go up. I'm so pleased that there are people here tuned in for this important discussion, and would call your attention to the article in today's Arizona Republic highlighting the findings of this Morrison report so that you can send them to your friends and colleagues to get them talking and thinking about the issues that are raised today. And they are critical. This is a very good expression of what Watts College is about, which is taking on the challenges that we face in our community, and not just lamenting them and not just wringing our hands about them, but using the tools that we have, which is the capacity to do empirical research and drive results-oriented action towards solutions. And what you're going to hear in the discussion today is that something that seems like a set of intractable problems, the challenges of chronic mental illness, the challenges of homelessness, the enormous costs of caring for the most vulnerable folks in our community, all of those are solvable challenges, and we know what the solutions are. We simply have to marshal the data to win support for policies that will make the world a better, more humane, more robust place. And so today we take on a fundamental issue, one that is important to Watts College, one that's important to Arizona State University, which is the intersection of issues around housing, behavioral health, homelessness, and the systems that we have in place to address those concerns. And I want to underscore what you are going to hear today that is different, that has been heard in previous discussions of these issues. The critical difference is that for the first time, we have been going through the data, looking at the costs associated with a subset of the population of Arizonans who are experiencing mental illness. It's a subset that is what we call chronically mentally ill, and what that means is that they are the most heavily engaged in the behavioral healthcare system. And what we can demonstrate empirically is that that subset of the population, first of all, drives a high percentage of the total costs, and second of all, could be remediated in a more efficacious manner if we increase the supply of known effective housing options that provide care, support, and interventions preemptively before things end up involving the criminal justice system and other systems at a more expensive cost, and after there's additional human suffering. And so here's one of these happy instances where the humane, ethical thing to do also turns out to be the cost-effective thing to do. And I think that actually happens more than we realize. We just need to be smart about it. I also want to make an important point about this report, which is, as critical an addition it is to our literature and understanding of these issues, it is the tip of the iceberg. You will hear from Morrison Institute and ASU researchers about the ways in which we try to capture the potential financial advantages of providing housing options for people who have chronic mental illness. But there are a variety of other dimensions which we did not yet capture. So let me just give a few instances of that, because it's really important, and I hope I will whet your appetite and maybe even excite a potential funder to drive this work. But let's just take another issue that we in Watts College care a great deal about, which is police interaction with the community and the specific challenge of officer-involved shootings. We know from research that's been done in Watts College and other places that more than 70% of officer-involved shootings involve somebody with some sort of mental health condition, either substance-related or some underlying mental health condition. So if you did a better job of managing people with chronic mental illness, it is an inescapable conclusion that the number of officer-involved shootings would go down, which first of all would reduce tragic fatalities, but it would also have huge cost implications in terms of the cost to the police department, the cost of the community, the cost of the healthcare system, the cost of litigation. Even if we didn't care at all about the morality of it, there would be an enormous financial gain. If we think about emergency rooms that spend a disproportionate of their energy caring for people with severe mental health issues, a better solution for that population would have enormous savings for our healthcare institutions and for the governmental resources that support some of those healthcare institutions. If we think about incarceration, where prisons have become de facto mental health institutions that make them less effective, less safe, and result in worse outcomes for people who are incarcerated and the communities that receive them, that would be improved. So we hope that this whets your appetite for more of this analysis and points in the direction of future research that will call upon policymakers to come up with better solutions. And we as a college are ready to implement them. We've launched the ASU Action Nexus to bring together solutions related to homelessness, behavioral health, and health equity are core concerns of the Watts College. And so we stand ready to take on this work to advance solutions for our community. It wouldn't be possible for us to do this work without the support of passionate members of the community who have taken it upon themselves to drive forward solutions to our most vexing problems. And I'm delighted that the next speaker will be one of those Arizona heroes. It's been my great pleasure to work with Lori Goldstein, who is the parent of a child who's now an adult living with behavioral and mental disorders. And she's been an absolutely indefatigable advocate on behalf of individuals like her son and families. And she and her husband, Chuck, who's been right there alongside with her, have been incredibly influential to bring these issues to the fore, working with the Mental Health Association of Arizona, founding the Association for the Chronically Mental Ill, which is a sponsor of this work, and pulls together stakeholders. Lori shows through her work in Arizona and more broadly sitting on Columbia's Global Mental Health International Advisory Board and working beyond Arizona, Lori shows what passionate individuals can do to influence public policy. And we are here today because of Lori and Chuck and Josh, who you hear from, and many others who have really moved the ball forward through their own engagement. And so we are enormously grateful to Lori and the ACMI for supporting this work, and we look forward to standing shoulder to shoulder as we advocate for these solutions and for a more enlightened public policy as it comes to the chronically mentally ill and the provision of appropriate housing solutions that benefit us all. Lori, thank you so much. I'll turn the virtual microphone or speaker over to you.
Well, thank you, Jonathan, for those kind words. But as all advocates for those who have a serious mental illness know, providing appropriate housing with supportive services is critical to stability. However, folklore is not enough to drive policy changes. There's been a failure to appreciate the impact of no treatment or undertreatment of this serious mental illness in multiple societal systems, as you mentioned, police, fire, emergency rooms, shared public places that are no longer available due to homelessness. The result is poorer outcomes and increased costs. We needed empirical research to back our assertions. As the ASU trustee, I have the privilege of seeing the impressive research that goes on at ASU. It's slated to be have $1 billion in research, which is greater than other universities without a medical school. But more importantly, at ASU Watts College, which Morrison is a part of, is dedicated to engaging in research targeted to solving actual societal issues. Its focus on applying research, the result of most academic research, takes 17 years to get into the hands of people that could use that research. And that is something that Watts and ASU is trying to change. After reading Richard's Reality, the Cost of Chronic Homelessness in Context, which was done by Morrison and Watts, we knew that ASU would be a great partner to help us study this issue and come up with real data. Now I'd like to introduce Josh Moselle. He is a senior law partner at Fraser, Ryan, Goldberg, and Arnold, where he specializes in a lot of behavioral health law. And he's the president of Association of Chronically Mentally Ill, also known as ACME. And to you, Josh. On mute.
I'm so bad at that. Thank you, Lori. Just wanted to give some brief background on how this got started from our end. ACME was founded in 2017 as a grassroots mental health organization. And from the beginning, we were focused on the population that Dean Capel was just talking about, the chronically mentally ill. We're also focused like a laser on outcomes. And what we're focused on was a particular type of housing. And in that housing, after an adequate period of pre-entry program, we saw that even those who are the chronically mentally ill that Jonathan described, who are cycling through emergency rooms, homelessness, our criminal justice system, who are having constant interaction with police and fire, even that group of people could not only stabilize, but then could do well. And because that was the case, we wanted to perpetuate that type of housing. So we began to meet with everyone we could that was impacted by that population. And it's really goes across the board. It's hospitals, insurers, police, fire, cities, counties, prosecutors, public defenders, the Department of Health, the Regional Behavioral Health Authority. We met with pretty much everyone. We let them know that this type of housing will save money, make lives better. And they all agreed without any hesitation. And then it came to the brass tacks, which was, so do you want to give us some money to build some of this? And they all kind of said, well, hold on, why don't you go prove it? And that was something we just couldn't do on our own. We needed the expertise of ASU. And the goal was to create, like Dean Capel was saying, actionable research that could be used in the real world to convince, to persuade. I remember our first meeting, I kept using the word weaponize, and Dean Capel said, let's find another word. So now it's actionable research. And so a couple of years ago, we started talks which culminate today with this study. And as an advocacy group, honestly, we couldn't be more excited, more grateful to ASU for their expertise and for the contribution this paper will make, not only to the existing body of research, but to shifting the systems and policy impacting the small sliver ACME has worked to help. So with that, I'm going to pass off to Allison Cook-Davis, who's the Associate Director of Research at Morrison Institute for Public Policy.
Thank you, Josh. Good afternoon. I would like to thank you all for joining us today. Our mission at Morrison Institute is to be a leader for independent, consequential public policy research. This study is an excellent example of how research can be used as a catalyst for dialogue to identify policy actions based on available data. I would like to thank the Association for the Chronically Mentally Ill, ACME, for sponsoring this study. Funding for the study was provided by the Charles and Laura Ann Goldstein Philanthropic Foundation and the BHHS Legacy Foundation. I would also like to acknowledge the agencies and individuals who helped us access the data needed to conduct these analyses, as well as the interview participants who provided their expertise. I would also like to acknowledge the efforts of many Morrison leaders and staff, as well as our collaborators from the Center for Health Information and Research who made this study possible. This quote highlights the widespread recognition among experts that housing is important for the stability of individuals experiencing mental illness. Existing housing options work well for many with serious mental illness, but not for all. Some people experience more severe, long-term symptoms and need a high level of support to manage their diseases. These individuals are considered to have a chronic mental illness. Many struggle with housing, treatment, homelessness, and jail, and the outcome results in high costs to the public. Throughout this presentation, we will show 3 short videos designed to help us communicate key findings concisely for a broad audience. Here's the first video entitled, "What is Chronic Mental Illness?"
In Arizona's public health system, people are diagnosed as having a serious mental illness if their disorder impairs their ability to function in a way that substantially interferes with or limits how they live. Over the past 6 years, nearly 34,000 Maricopa County residents enrolled in Arizona's Medicaid system were determined to have a serious mental illness. Among people with serious mental illness, there is a subset who experience more chronic, severe symptoms and recurrent crisis episodes. They may not follow a treatment plan, or they may not have found a treatment that is right for them. About 6,300 people, 18% of people with serious mental illness were identified as having chronic mental illness in Maricopa County. People who experience chronic mental illness are a unique population. Unfortunately, they are treated the same in our public health system as people who have serious but well-managed mental illnesses. When people with chronic mental illness experience symptoms of their disorder, they may endure significant instability in their living situation. They're likely to cycle among hospitals, jails, short-term shelters, and homelessness. This instability can exacerbate their symptoms, and their use of these high-cost services comes at a significant financial cost to the state. To stabilize and recover, people with chronic mental illness need intensive support in the short and long term. They need medical care that is managed the same way heart disease, diabetes, or other chronic conditions are treated, over a lifetime.
The Medicaid agency for Arizona is the Arizona Health Cost Containment System, or ACCESS. It provides coordination, planning, administration, regulation, and monitoring of all of Arizona's public behavioral health system. In addition, ACCESS contracts with regional behavioral health authorities, or REBAs, to deliver integrated physical and behavioral health services to Medicaid-eligible individuals with serious mental illness. Since 2013, Mercy Care has been contracted as the REBA for Central Arizona, which includes Maricopa County, and provides services and supports for individuals with serious mental illness. While Medicaid funds may not be used for housing, Access plays an important coordination role and engages with community stakeholders to augment the Medicaid system's ability to address housing and other social determinants of health. This figure shown here was developed by Access to show the spectrum of treatment and the housing continuum. On the left side in red shows the treatment-focused end of that continuum. For individuals experiencing a behavioral health crisis, there are restrictive settings with professional supervision, such as the Arizona State Hospital. For individuals who are experiencing behavioral health issues and may be at risk of going into a more restrictive setting, there are settings focused on treatment with professional supervision and voluntary services. These examples are in green and include behavioral health residential facilities and adult behavioral health therapeutic homes. And the blue arrows on the right show the housing that's focused in the community with voluntary support services. Based on national proportions, it's estimated that over 139,000 individuals have a serious mental illness in Maricopa County. In 2019, Mercy Care served over 34,000 individuals with SMI. There were 5,221 beds, which is about 15% of the SMI individuals served. Maricopa County has more available housing for individuals with SMI compared to the national average, but several studies have shown experts feel more housing, treatment, and support is needed for here in Maricopa County for individuals with serious mental illness and chronic mental illness. There's not enough housing supply to meet the needs of individuals with serious mental illness and chronic mental illness. Homelessness and jail are not uncommon housing situations for the individuals with serious mental illness. There were 965 individuals who self-reported a mental illness. However, this number is likely higher. Officials estimate 1,100 individuals with serious mental illnesses are housed in Maricopa County Jail. Given the high prevalence of homelessness and incarceration among this population, housing is widely recognized as an important factor in combination with appropriate treatment and supports. Affordable housing has become a greater challenge for everyone. Currently, in Phoenix alone, the demand for affordable housing is much higher than the supply, with an estimated 163,000 units required to meet the demand. Among individuals who are extremely cost burdened, those who pay 50% or more of their income in rent, 40% of these individuals do not receive rental assistance. There is a consistent wait list for vouchers, and there's a lottery to be put on the wait list. Mercy Care operates a permanent supportive housing program that helps members with serious mental illness experiencing homeless access housing, but there's not enough vouchers and subsidies to meet the demand. Additional supports and housing are provided by family, friends, advocacy groups, faith-based organizations, and other social groups, which are outside of the access system, but are critical to the recovery for many. With this project, we set out to better understand whether housing and supports impact public spending for individuals with chronic mental illness, and to identify recommendations from experts on how to improve care and reduce costs for this population. This study has 3 parts. We conducted a comparative analysis of how housing and in-home supports affect public spending on individuals with chronic mental illness in Maricopa County, based on 6 years of data from 2014 to 2019. We conducted a small sample case study of the Lighthouse Model Community Homes managed by Copa Health. These include 2 group homes that provide individualized 24/7 in-home professional support. The goal of the lighthouses is to provide stable and supportive conditions individualized to their tenants in a community-based setting. These are the only 2 group homes like this in Maricopa County. In this portion of the study, we examined costs for this population before and after moving into lighthouses. We also conducted interviews with 36 experts who work with and care for individuals with chronic mental illness, and they provided recommendations for reducing costs and improving care. Morrison Institute closely collaborated with the Center for Health Information Research, also known as CHEER, at the College of Health Solutions at ASU. CHEER is a partner and community resource that provides comprehensive health information, data analytics, and reporting for both public and private research endeavors. CHAIR collects and analyzes health and social determinants data from a variety of sources in their secure central repository. All of this data are linkable, creating one of the most complete and accurate longitudinal profiles of individuals and populations over time and across providers and insurers in Arizona. I would like to introduce Gavor Karatunyan, who led the CHAIR team as the principal statistical programmer. He has recently moved into a new role as Vice President of Data Analytics and Technology at the Arizona Alliance of Community Health Centers. He will walk us through the cost analysis.
Thank you, Allison. So I'll be your ambassador through the cost analysis, and we have a lot to cover, so please bear with me on the pace. Data is a critical key to understanding populations, their needs, the barriers, and how to design solutions for them. Unfortunately, individuals with chronic mental illness traverse many complex and often disconnected systems and networks of service and care. To get a comprehensive view, one needs data from housing, social services, healthcare, criminal justice, and so on. We will discuss the results that we're going to discuss came from data collected under 3 different business associate agreements. This is the legal agreement used when transferring protected health information, 1 intergovernmental agreement, and 1 data use agreement. It took many months to get these agreements in place. And even after that litigious exercise, we still had to acquire the data itself. And that's when the even less glamorous but essential work began of harmonizing the data. You see, data are collected for different reasons, contain different biases, different levels and types of messiness, even different definitions for similar concept. And as we mentioned before, are often disparate without common linking identifiers. As such, immense work went into creating cohesion, including matching individuals using probabilistic matching algorithms across these data sources where necessary. And I'll spare you all the gritty details, but I say all this just to say, work like this one is often built on unseen infrastructure and data projects. I've had the good fortune of having a career in these unseen sorts of projects, and I want you to keep that in mind as we walk through these results. I thank all of our stakeholders for being willing to come to this table and share their data, and I urge all organizations to come to such tables, build interoperability, and share your data for the greater good. So after acquiring the data, the first key task we had was, how do we define chronic mental illness in our data? Others who had worked in the space had often focused on high-cost individuals, which is fair, but we wanted to stay away from this to avoid confounding with what we saw as one of the most influential metrics in our discussion, cost. We wanted to ground this in something more clinical. We looked at the language, the legal definition of the legal language for secure placement. This language was defined for a case-by-case basis, but we were able to extract and operationalize a definition to apply to the data, which I will patronizingly read to you now. It's on your screen. To be classified as CMI, you had to first be designated as having serious mental illness and 2 episodes of crisis, and those episodes did not meet recommended follow-up treatment, and either were arrested for a crime, made a claim for suicide, intentional self-harm, or continued to experience recurrent crisis episodes, all within a 24-month window. When presented, the group as a whole felt that this captured the spirit of the legal language, so we moved forward in applying this definition. On the about 34,000 individuals in Maricopa County that were designated as having serious mental illness, a little over 6,000 or 18.5% were further classified by our definition as having a chronic mental illness. Now, a key goal of our work, which you can obviously tell from its name, was to understand the role housing played and the impacts of different housing settings on chronic mental illness. So the next key task, obviously, was defining and categorizing housing settings. Using HMIS data and access data, we identified 3 housing settings: chronic homelessness, permanent support housing, and those housed in unknown supportive services. This last category were people consistently in residential housing, but there was an absence of information or detailed information on their support level. To be classified in any of these categories, an individual had to be consistently in that setting for at least 180 days or more within a couple years of that CMI designation. Using this, we were able to capture 31% of our previously defined CMI population. And you can see on your screen how those numbers broke down. Thus, now we have our sample from which to draw findings. But before we go on, we have summarized some of those findings in a video that you can share. And so I'm going to take a quick pause so we can share it with you.
Arizona State University's Morrison Institute for Public Policy interviewed dozens of experts who care for people with chronic mental illness. A legal professional who was interviewed contrasted how we care for people with Alzheimer's with how we care for people experiencing chronic mental illness. We don't let people with Alzheimer's wander the streets until they do something illegal and end up in jail, or until they hurt themselves and end up in the hospital. Why don't we give people with chronic mental illness the level of care they need to avoid these negative outcomes? Through no fault of their own, people with chronic mental illness have recurrent crisis episodes when their symptoms are not well managed. They often end up cycling through our crisis systems, like emergency rooms and jails, and on the street. This revolving door can make their illnesses worse, often at major financial cost to the public. Providing permanent housing and individualized support services actually costs less than if a person with chronic mental illness experiences chronic homelessness. On average, it costs about $73,000 annually to provide housing, healthcare, and criminal justice services to a person with chronic mental illness who is experiencing chronic homelessness in Maricopa County. In comparison, those same services for a person with chronic mental illness who has permanent supportive housing cost about $52,000 on average. That's a difference of almost 29%. By providing permanent supporting housing with appropriate support to people with chronic mental illness in Maricopa County, the public could be saving about $21,000 per person per year.
All right, let's dive right into the results. Here we have the average for an individual with chronic mental illness, CMI, in each housing setting per year. Thus, this is an annualized cost per person. The blue band is health, orange band is housing, and that gray band on the top is criminal justice. The blue health band is calculated from allowed amounts from Medicaid claims and encounters. The orange housing band is estimates from census and HUD based on where the individual lived, and the gray criminal justice costs are estimates from average estimates of court, booking, per diem, police, all found in budgets and reports. Those who experience chronic homelessness incur the highest average cost in all three categories, while those in permanent supportive housing incur the lowest overall cost. The difference between the two is nearly $21,000 or 28.7% difference. Most of the cost difference is driven by health costs, as they constitute roughly 70 to 80% of the estimated costs for an individual with CMI. Now, putting health aside, let's focus on the criminal justice band to look at breakdowns by police in blue, incarceration in orange, and court costs in gray. For this data, we had reliable individual indicators for incarceration events, but costs were population level estimates from budgets and reports. Happy to expand on that further in the QA. This graph represents the average cost across the population. Not everyone in the population had a criminal justice interaction. In fact, the breakdown is about a third in the permanent supportive group, 1/4 in the unknown support service group, and about 30% for those that were experiencing chronic homelessness. As such, we see that those living in chronic homelessness have nearly $5,500 a person a year cost, while those in permanent supportive housing have $3,200 in cost, a difference of $2,300, or a 40% difference. Moving to health costs, in this graph, we have divided up costs between behavioral health, blue, physical health, orange, and pharmacy costs in gray. Costs were categorized by the primary diagnosis, with pharmacy being a carve-out. As we saw earlier, health costs are the highest among those in chronic homelessness and lowest amongst those in permanent supportive housing, with a 32% difference. Spending on pharmaceuticals amongst the chronically homeless were twice that of the permanent support group and 45% higher than those housed with unknown supports. In addition to the volume, the proportion was also higher at about 31% of their total health costs versus approximately 20% for the other two groups. Now, those in permanent supportive housing received a higher proportion of their total health spend compared to the other two groups in spend directed at their physical health needs, indicating a more balanced integration of care. Now, unsurprisingly, all three groups have the highest amount and proportion of their spend in behavioral health. I think that's quite understandable. Next, I want to look at a setting that we generally talk about as a high cost setting, and that's hospital inpatient. The definition here is individuals enter the inpatient setting in a variety of different ways, but ultimately, if they got admitted, I was counting all of their costs as inpatient. So those living in chronic homelessness had the largest volume of costs in the inpatient setting, with nearly $6,000 a year per person. A $6,000 difference between that population and those in the permanent supportive housing group. Now, it's important to keep in mind, despite this large difference in absolute value, the proportion of inpatient costs for their health costs was approximately the same across all groups. That is, 30% inpatient costs were about 30% of their health costs in all three groups. Now, a surprising finding within the behavioral health sub-analysis was the cost of this other mental health and substance use treatments. This is an aggregated category that includes residential treatment centers, rehab programs, drug and alcohol service, mental health assessments, and therapies. Now, we see the common pattern that is expressed across many of the visuals I've presented to you, with individuals living in chronic homelessness showing higher costs than those in permanent supportive housing. But here we see a large amount of the spend for those housed with unknown support services. Now, the large bulk of this spend are in short residential treatment center stays, a possible indication of costs associated with inadequate support. Within our study sample, a subpopulation of about 78 people were identified who transitioned from chronic homelessness into a permanent supportive housing setting within our study period. Now, they all met the previous criteria and requirements we've discussed. These 78 people constitute about 10% of our chronic homelessness group, the population I've been showing you all along. Among this group, the average cost per person quite rapidly declined by $6,000 or 10% after transitioning into that permanent supportive housing setting. Since we expect the bulk of the cost savings to be realized over time as health and social needs stabilize, we might expect this difference to continue to grow if we were able to observe this group for longer, a limitation of the study. And this is very exciting. This is a natural pairwise control group. These are the same people with the same needs. And it really underscores the value of housing, specifically housing with support for those with chronic mental illness. Now I want to transition back to discussing about the Lighthouse model, which Allison introduced earlier. This is a unique model that provides stable, long-term housing with 24/7 in-home support, coupled with a person-centered philosophy. Tenants sign an annual lease, pay 30% of their income to rent. Each tenant has an individualized treatment plan, and they can come and go per that plan. So their autonomy falls somewhere between that of a nursing home and independent living. More importantly, they're not penalized for their CMI symptoms. Penalties that might be observed in other settings or may be interpreted in other settings as quote unquote bad behavior. Tenants can return after hospitalization, after treatment, after arrests. Effectively, they work to avoid eviction. Now, there's much more to this than that. and I'm not doing it justice. So I recommend each of you to pick up the report and read about the Lighthouse. But I'd like to talk a little bit about their data. Now, keep in mind, this is a quite small N group. There's only 9 people represented in this population. But right away, you'll notice this is a very high cost group of individuals. Previously, we were looking at average health costs around $35,000 to $55,000 per year per person. This group is 2 to 3 times higher in cost. Now, in 2016, all 9 individuals were present in our data and had not yet entered the Lighthouse. In 2017, one of the 2 homes were set up and residents had fully moved in. And by 2018, both houses were fully occupied with all 9 residents. So taking the average of the 2 post-entry years, the average in annual spending in healthcare per tenant was reduced by about $18,000 or 15%. This is larger than what I just showed you with the 78 sample a slide ago. So let's take a look at the shifting costs by some of the categories we discussed earlier. The largest change we see is a reduction in that behavioral health spending, which fell about 36% from 2016 to 2019, pre and post. A small portion of this was replaced by higher spending to address physical health needs, more than doubling in spending from 2016 to 2019 and continues to steadily grow and is in line with integrated mental health behavioral models. In addition, we observe an increase in spending on pharmaceuticals, which effectively quadrupled, although the bulk of that increase was shortly after entry. Now, I want to take a moment to caution that in descriptive cost analysis like this one, it is often unclear what is a driver versus what is a response. I feel like it's my responsibility to say that to you as you absorb this information. But looking at this graph, we observe a large spend in that other mental health and substance use category we discussed before, and it's in yellow there, from $73,000 per year per person pre-Lighthouse to a near elimination, a reduction of $68,000 to a total of $5,000. So that's $73,000 to $5,000 from 2016 to 2019. And again, some part of that is replaced, and it's replaced by an investment in skills training, which went from 1,700 pre-Lighthouse to nearly 40,000 post. Now, skills training, that includes living skills, health promotion, job training, education, and much, much more. Essentially, it's an investment in the person. To put it in context, pre-Lighthouse, this investment was about 1% of their total health cost. By 2019, it was over 35%. And that is truly remarkable. Thank you very much. I have the distinct pleasure to introduce your next presenter and my esteemed colleague, Chrissy Bausch of the Morrison Institute.
Thank you so much. Good work. One of the goals of the study was to identify recommendations for improving care and reducing costs for individuals with chronic mental illness in Maricopa County. To achieve this, we turned to local experts. As you can see in the chart on the right, I conducted semi-structured interviews with healthcare and housing providers, emergency responders, individuals with chronic mental illness, family members, among other experts, for a total of 41 participants. I identified participants on organization websites as well as by recommendation from other interviewees. I analyzed the interview transcripts and notes using an inductive approach that allowed themes to emerge from the source material. The third video in our series summarizes the key message we heard from experts that for individuals with chronic mental illness, housing helps most when it's combined with appropriate treatment and supports. And as we saw in Gavork's presentation, the results of the cost analysis support interviewees' perspectives that providing permanent supportive housing to this population reduces overall costs. Let's watch that video now.
Arizona State University's Morrison Institute for Public Policy interviewed dozens of experts who care for people with chronic mental illness to identify policy solutions that could help improve lives. Interview participants saw stable, affordable housing as an essential part of care that can reduce interactions with crisis, justice, and homelessness systems, as well as financial costs. To be successful, however, housing must be combined with appropriate long-term treatment and support. A homeless services provider was one of many experts who told us housing is healthcare. Having a safe place to live has mental and physical health benefits for everyone. People with chronic mental illness find even greater health benefits in housing when they receive supportive services at home. But in Maricopa County and across Arizona, it is difficult for people with chronic mental illness to access the level of in-home support that they need. Experts who spoke with Morrison Institute recommended offering more long-term housing options and higher levels of support, such as 24/7 professional support staff and life skills training. A legal professional who was interviewed by Morrison Institute put it plainly: any kind of residence that we put a person with chronic mental illness in, if we don't give them the right kind of services, we fail them. We've got to have the services available to wrap around that person. Morrison Institute has compiled its research findings and recommendations related to chronic mental illness in Maricopa County into a detailed report. To read the full report, visit morrisoninstitute.asu.edu.
So now let's dive into specific recommendations that experts shared with us on improving care and reducing costs. First is to provide higher levels of treatment and support. After a crisis episode, many individuals with chronic mental illness can benefit from more time under professional supervision. They might need treatment for a co-occurring substance use disorder. Participants recommended making more residential treatment options available that can meet those needs. After treatment, individuals with CMI still have high support needs. Participants suggested providing more permanent supportive housing with up to 24/7 in-home support, where residents or tenants also have opportunities for recreation, skills training, community building, and other key elements of well-being, where they won't be evicted when they experience symptoms of their illness. As one law enforcement professional explained, there's not really a lot of places that can manage people when they're symptomatic and keep them housed. So it'd be nice to have something in the middle, between a complete lockdown, secure hospital setting, to out in the community. Participants also spoke to the need to meet the long-term support needs of individuals with chronic mental illness. For example, a family member made this comparison. If you have diabetes, you need care literally for your whole life, and some people's diabetes is more severe than others. You need more intensive care. Well, it's the same thing with mental illness. In practice, this might mean having more housing settings and in-home supports that are not time limited, that an individual can benefit from for as long as they need to. Interviewees spoke to setting realistic expectations for recovery. Some individuals with chronic mental illness may have high support needs for their whole life. They may struggle to follow house rules or not adhere to treatment. Many will experience occasional crisis episodes, substance use, or criminal justice interactions. And interviewees pointed out that these can be really challenging, expensive situations for providers and families that often result in eviction from their housing. But interviewees also pointed out that these are symptoms of chronic mental illness that should be expected and greeted with treatment and support. A supportive housing provider explained how their organization has adjusted their expectations when working with this population. These are people. They're going to make decisions that later on they might regret. And let's go into this knowing that and accepting that and saying that part of our program is dealing with that and then saying, what does our program need to look like in order to achieve some level of success? Of course, it's hard to talk about housing in Arizona without recognizing that many populations are struggling to access housing. And this theme came up a lot with the experts I spoke with. Not only do individuals with chronic and serious mental illness need affordable housing, they also need appropriate levels of treatment and support, which, as we've been discussing, can be hard to access. Many interviewees saw this as at least in part a capacity issue and recommended increasing the supply of appropriate housing. A legal professional told me, I've found whether it's housing or it's hospital beds or it's residentials to go to, if you open up capacity, then all of a sudden, all of those bureaucratic barriers go away. So to me, the bottom line is we need more units. A related recommendation was around the need for public support from voters and decision makers across levels of government to fund appropriate housing for this population and welcome it into their communities. A behavioral health professional spoke to this, saying, it comes down to voters and government. They need to put more money into our society's most vulnerable. Participants also emphasized the important role of social connection and community integration for well-being and recovery. Family, friends, employment, hobbies, and other outlets and relationships can all boost quality of life for individuals with chronic mental illness, just like everyone else. So when an individual is ready, participants encouraged integrating those types of opportunities into treatment plans and getting the broader community involved to offer connection, employment, and volunteer opportunities. As one law enforcement professional explained, if they're starting to get to where they can manage their illness, are we working to partner with local businesses to see, can we get this person a job? Even if it's not enough to pay the rent, there's that sense of accomplishment, that interpersonal and the leisure part. Are we talking to them about what are your hobbies? There are more expert recommendations in the report, and I invite you all to download it from the Morrison Institute website and dive in. Please put any questions you have in the Q&A or follow up with me via email. And with that, I'll turn it over to Andrea to moderate the discussion.
Wonderful. Well, thank you so much, Chrissy, and thanks to all of our presenters. And for those of our panelists who are going to be participating in the Q&A, if you can turn your cameras and your audio back on. So I hope to those of you watching that you found this both informative and also useful as you think about how you or your organization can improve the systems that serve individuals with chronic mental illness and improve their quality of life. So we did have a number of questions that have been submitted in the chat, so I'm going to jump into those. So our first question, is there a place in the continuum of care for people with chronic mental illness who do not meet the medical need criteria for an inpatient locked facility, but who will not stay in a residential unlocked facility? And there were actually a couple of questions that sort of touched on the same issue. And so I wonder if maybe Josh or Lori, do you want to jump in first on this one?
Okay, so it's one of the things that ACME was really instrumental in helping bring a new level of care, because once you don't meet a medical necessity, you're discharged out of a hospital. But if you lack insight, you're going to start this vicious cycle over and over. So it's in process right now. We were grateful to Senator Bartow to help with the legislation and get it passed. And right now it is actually in the process of being built, and it would be like a lighthouse, but secure. And Josh, do you want to jump in?
Yeah, just real quick, I think that in dealing with this chronically mentally ill population, that was the biggest issue, is that people would go to the hospital, they'd improve, but they'd come out and they would still need treatment, whether it's medication or other types of treatment modalities, but they couldn't get it. And then I'd have clients who we'd say they're gonna leave in a day, in a week, and they'd leave in hours, and then they'd enter that cycle. And so building a secured facility that's less than a level 1 psych facility, but more than a 24-hour residential was what was required. And that is currently not available, but the law's been passed, money's been allocated, and we hope to soon have it built.
Great, thanks, Lori and Josh. So here's another question that was submitted. They wrote, thank you for quantifying the public cost of a lack of reliable housing for those experiencing CMI. Unfortunately, NIMBYism causes neighborhoods to largely oppose these community solutions, even during a global pandemic or when it's in our collective economic interest. What do you say to those skeptics who continue to vote against those economic interests?
Jonathan, I mean,
so it's a great question. I have some up close and personal encounters with the neighborhood concerns regarding siting of services that are utilized by these populations. I think first of all, part of this is things like the kind of work that we're talking about today, where you get facts to counter perception, are important. So, for instance, not covered in this research, but something that we should contemplate is a documentation of whether, in fact, there is crime or negative externalities associated with lighthouses. I would posit to you that the answer is no, but it's something that we can speak to. I think advocating for solutions that don't place all facilities in one neighborhood or in one city is important, because there's no doubt that the more you concentrate these things, the greater the risk is of some sort of negative outcome. But at the same time, you have to be mindful of the situations that make these kinds of options reasonable. So somebody who's in this CMI category may not have a driver's license or a vehicle, and so locating them in a way that's not proximate to mass transit options in the interest of scatter site placement is nonsensical, because you're asking for something that will be a failure. And then I'd say lastly, this is an area where there has to be pressure put upon elected officials to speak truth to perception, and to advocate for solutions in their own districts, in their own communities. This is not a problem that can be allowed to shift to where the water is willing to flow. And again, this study doesn't deal with where these individuals are located, but I can tell you, as somebody who's very involved in the issues of homelessness and behavioral health, no community has a monopoly on CMI populations. Every municipality in Maricopa County has this challenge, and every community in Maricopa County should be looking for solutions. And by the way, not just Maricopa County. I was pleased to see in the chat there was a comment from a provider in, I think it was Navajo County, and this is a huge issue in rural Arizona as well. Again, not contemplated in this research, but something that needs to be taken on. So I think it's not one solution. The problem is that what we've seen is that the responsibility for combating NIMBYism generally falls upon the provider, and then you have this weird situation where people are, and again, I encountered this personally, where people are fighting for the right to take care of the most vulnerable in our community. Like, that's wacky. That's wacky. We should all feel like this is a problem that we need to deal with. And I'll say in this conversation, even though it's a little more complicated than this, we are actually doing well in Arizona. That's the part. If you want to see what happens when you don't address this problem correctly, all you have to do is get on I-10 and check out Los Angeles and see what happens when you let this problem and the problem of uncontrolled housing costs escape your grasp. That's what happens. And it seems almost insurmountable. So now is the time to take the lessons of this report and other learnings and get on top of it, because if you don't, the problem grows to something that's almost impossible to digest.
Thanks, Dean Capel. So I think we have time for one more question, so I'm going to try to make it a twofer. I'm curious where Arizona can look to for examples of other ways to manage housing and costs for vulnerable populations, and what might be the next steps in researching this issue, building on the foundation that this work has laid. Chrissy, do you want to take that first piece?
Yeah, I'll take a stab at the first piece and see if anyone else wants to build on my response. Participants in the interviews recommended looking to a lot of places, both nationally and internationally. Some of those places that Arizona could look to were New York, Ohio, Belgium, Italy, just to name a few. And I'll provide a quick example. Los Angeles County is now considering a 5-year pilot program modeled after a city in northeastern Italy called Trieste. I won't get into the details now, but this might sum it up nicely. Experts have said that if you're seriously mentally ill, this is the place you would want to be in the world. Their program is of that caliber, and so there are some pretty key differences between how Arizona is operating and how Trieste is operating, and so a comparison between those places could be very interesting and illuminating.
Wonderful. Thank you, Chrissy. Any other final comments from our panelists related to future directions for research?
I think that there's a lot of opportunities for additional research in this area. Dean Capel mentioned a few at the beginning of this webinar. looking at additional costs in the criminal justice system. For example, time spent by police attending to calls that do not result in arrest, but do take away police from other duties. In addition, I think it would be important to look at the match between the needs of individuals and the housing and supports available, and identifying how to sort of better match in order to increase stabilization, and potentially that would also result in additional cost savings.
Great, thank you, Allison. Well, as you can see, this is a rich and very important discussion on what is clearly a complex issue. So I see we're out of time, and I'll go ahead and wrap things up. I just want to express my gratitude to everybody on the research team, to the funders and sponsors of this study. You know, this would not be possible without a lot of people behind the scenes making it happen. I encourage you to download the report, to share it, to share the links to the videos with people in your network. And if you have additional questions, we're happy to answer those. You can contact us at Morrison Institute. And also, if you are interested in further engaging on this subject, I wanted to make you aware that the Association for the Chronically Mentally Ill is hosting its own educational webinar on this body of work on May 26th from 6 to 7:30 p.m. So if you would like to attend, or if you know people who might be interested, please help us spread the word. You can see, I think we've put a link in the chat. And so with that, thank you so much for joining us, and enjoy the rest of your day. Take care.